Good afternoon, everybody, or depending where you are in the world, good morning or even good morning or good evening. Welcome to the webinar of the Geriatric Emergency Department Collaborative. My name is Melady. I'm an emergency physician at Mount Sinai Hospital in Toronto, Canada, and I'm one of the faculty with the Geriatric Emergency Department Collaborative. We are continuing in our series of webinars about strategies to create a geriatric emergency department. Most of our other, many of our other webinars have been on the clinical components of emergency department care for older people. And today we wanted to focus on us, the providers, and how we can improve our abilities within the geriatric emergency department. So we're talking about education and how to create valuable education to improve the quality of the workforce. We're using a broad lens to think about education for everyone: doctors, nurses, physiotherapists, social workers, also non-clinical staff like security, housekeeping, registration clerks. Everyone needs to be needs additional abilities around care of older people. I'm using the term education to mean skills, knowledge, and attitudes, and how all of them can be enhanced to improve the care for our focus group, older patients, and outcomes for them. We've got a diverse audience on the webinar today, and I was very pleased. This is one of the highest pre-registrations we've ever had, so it's clear that people are interested in the topic. As we get started, can you please text into the chat box where you're calling in from and what your role at that place is. Next slide. The Geriatric Emergency Department Collaborative is a network of hospitals and healthcare systems from around the world at this point. We educate ED clinicians about models of care, and we're fulfilling that role today. We support emergency departments for how to improve their care, and we're doing that here today as well, and we research and evaluate outcomes. Next slide. If you're interested or share that vision, please consider joining us. We welcome new partners. Membership is currently free. We'll text into the box where you can access that. Next slide, please. The GEDC is generously supported by the John A. Hartford Foundation and West Health Institute, and we really value their support in all regards, their grant funding, but also their active partnership with our activities. Next slide. So our topic today is how to create an educated workforce for the Geriatric Emergency Department. The webinar is being recorded and will be available on the GEDC website within the week. And as well as all of our previous webinars stretching back over the past 3 years now, which cover really the whole range of topics about care of older people in emergency departments, everything from delirium screening to falls assessment to how to finance and fund improvements in geriatric care, telemedicine, interdisciplinary care, and so on. Next slide, please. We asked when you registered for you to answer a simple question. What is it that makes an educational experience successful? Everybody on this call has a lot of experience with being at least on the receiving end of education and probably on the giving end as well. It was very interesting. We had a lot of responses, but there were several very clear themes which align completely with what we're presenting today and some of the theories around adult education. On the screen at the moment, you'll see some of just a few of them. It's interesting that many of them have used the same words. So active, practical, relevant to the adult learner, relevant to the emergency department, it was amazing how often the term real life came up, and it was remarkable how often the term application or applicable or realistic were mentioned. So during today's webinar, we hope that you're going to enhance your understanding of some of the ways that you can do good education. We hope you'll get some guidance about how to create it, and we're going to illustrate it, as you wanted, with practical examples from around North America, brief descriptions of folks who have implemented education programs. Next slide, please. So our panel for today, we're very happy to have many revisitors, in fact. Pam Martin is a nurse practitioner who's led geriatric emergency department activities for more than a decade, close to 2. She currently works in the Department of Geriatrics at Yale New Haven Health and coordinates the development of accredited geriatric EDs in that system. Maura Kennedy is an emergency physician and the lead of the geriatric emergency medicine program at Massachusetts General. Tony Rosen is an emergency physician at New York Presbyterian Hospital who completed a fellowship in geriatric emergency medicine and leads their vulnerable adult abuse programs. And I'm actually joining as a panelist as well in my role as an educator. I'm an emergency physician. I'm also the director of a fellowship in geriatric emergency medicine and completed a master's in adult education. And all of that happens at Mount Sinai Hospital at the University of Toronto. We're also going, as I mentioned, going to hear from 3 sites and 3 sets of presenters from around North America, and I'll introduce each one of them as we get to them. So that's the end of the slides. Laura, you can go back to full screen at this point. I'm going to, before we get to hearing from our panel, I just want to introduce a little bit of adult education theory, which is usually the place where people start to go to sleep. But I do think there are some valuable things for us to keep in mind. Many of you are familiar with the work of Malcolm Knowles, who is famous within the field of education for developing the theory of the adult learner. We know intuitively that we as adults are different from children in the way we approach learning, but Knowles really helped us to kind of codify and describe the different ways that we are, that those differences take place. I'm going to ask Connor to just pop into the chat a couple of the key points. So adult learners, our adult learning colleagues have a view of ourselves as being self-directed. So while it's true that for a child, you can often get them to learn the capitals of the states or their colors or numbers or even how to play a piano just by telling them that this is important and it's something that you need to do. We know that doesn't work for your average emergency doctor or nurse or any adult learner. So unlike kids, adults need to have an internal motivation for doing it. But unlike children, we also have a wealth of experiences that we bring to any learning task. And as educators, we need to keep that in mind. So this is a concept called scaffolding, which is, I think, really important. And that's the idea that we use, as adults, we use all of our previous experiences as a scaffold to build on and to build our scaffold higher to get to where we want to go. So every educational activity needs to keep that in mind. So for example, a first-year nursing student has probably never seen a confused or agitated person before. However, every emergency nurse has seen a crystal meth user who's agitated or a head-injured person who's drowsy, knows how to apply a Richmond agitation sedation score from conscious sedations. So that person can build on that knowledge as we try to teach them about hyperactive or hypoactive delirium. Further, many components of Knowles' theory that I won't go into. I think the other 3 important ones are that adult learners typically are task-oriented. We have a job to do. We want to know what we need to know to do the job we need to do. We tend to be problem solvers, and our goal for doing what we do is always internal. these are things that we as educators need to keep in mind when we're designing educational programs. And as we go through these, you're going to find that that's what most of these successful educational projects have done. So I'm now going to turn to our panel of experts, and I'm going to start with Pam. You've been involved in educational activities for a long time and have done a lot of different things. Can you just describe a few of the ones that you found particularly successful?
Yes, Don, thank you. So a couple, I'm going to kind of take this in two directions, ED specific, and then kind of hospital and, hospital health system community. So ED specific ones that have been very, very successful have been a modified virtual dementia tour or that virtual dementia experience. So we actually took the virtual dementia experience and made it more of a cognitive and sensory experience for the older adult. We used staff meetings or huddles and sometimes just did small pieces of it. So, doing the vision with the glasses and having them actually try to read something or do a task, as your patient comes into the emergency department, we're putting papers in front of them for them to sign or computer screen. So, having them experience what that would look like if you did not have your glasses with you. Hearing, putting cotton or we actually had tape recorders that actually had taped noises just in an inpatient unit. And so we would have the person put that on and then try to have a conversation with them. So you would hear the bells going off, the people talking in the hallway, those kinds of noises, and just see how that interfered with what they were actually able to hear and understand. We also, with that experience, did a kind of a peripheral neuropathy. So if you saw somebody kind of walking slowly, or we did the gloves with cotton in the tips to kind of simulate arthritis and having them open a pill bottle, or we had Tic Tacs in the pill bottle, so having them try to pick up a pill. So doing some of those activities, and you could see how difficult they were for you to accomplish, and then even thinking about it. This experience we also did with the Alzheimer's Association, and they actually brought in some really nice additional activities with the cognitive experience, and actually one that we had never thought about were losses. So thinking about the losses that an older adult may have experienced before they even get to you. And so what they had them do was write down 3 things that means a lot to you. It could be an actual person, a thing, or it could be a feeling. So it might be, or something like independence. And then you would have them give you one. So you would just go around and take one of their pieces of paper. They had the opportunity to give you one. The next time, you actually just took one from them. And then they were left with whatever was left. And, people, at the end of that, we had people crying because, we maybe took their kids or they took their dog. But when you pull that all back together, and what does that mean for a person coming into the emergency department, right? A 90-year-old has probably experienced quite a few losses, where they've seen their family member or friends come to the emergency department and then not be able to come back home. So kind of thinking about that and putting it into the context of, what is this patient experiencing as they're even thinking about coming to the emergency department? So it kind of put a little perspective on that for us.
Pam, could I just ask one question? It's very interesting, this whole experiential component. Where have you used, where have you done that? With nursing staff, or in what setting?
We have done it with nursing staff. We have done it with community providers. We actually we did it with our local police station officers. So police training, EMS training, Yeah, so kind of multiple places. Upper management at the hospital, the first time we did it with them, that's I think how we kind of got a lot of buy-in for our senior adult program, is we actually just had one or two people like come up in one of their meetings and just had like them do, like one person did one thing and then talked about that experience with the rest of them, and we got lots of buy-in on that with their older adult other programs. Other things that were successful, especially with nursing education that I've done, was reserving the computer lab so that we could actually have dedicated time to actually have, kind of talk about why we're doing dementia education or delirium education in the ER, but actually take a case and have them share stories of what they would do and how they would work through it, and then how you would document that and talk about the importance of, why are we doing delirium screening in the ED? Why do we care about dementia in the ED? So kind of building on those adult learning principles of this is an ED setting and why is this important in the ED, so that they could reinforce that, but they could also share stories with each other with that. And like we kind of talked about some of the hospital and healthcare, the simulations with the College of Nursing. So if we were doing falls, we would kind of create fall scenarios and use their simulation lab. We also did some symposiums. So twice a year we would offer geriatric education. Like, the year would be, maybe the title was falls, and we do simulation at one and then a symposium at the other. The symposium always included breakout groups, so you could get some small group learning in as well, but you got to move through all the groups, and also included resources. So one group might just be community resources. So you'd have your area agency on aging, your Alzheimer's Association, if there was a clinic or PT, whoever could be there to kind of let us know what community resources we had at that particular time.
Pam, if you've got a few final points, I'll ask you to wrap up fairly soon.
That's it.
I don't believe that that's all you know, because you've been doing this for a long time. I suspect you could keep on going for a long time, but those are really great points. And actually, so it's interesting that you're talking about dementia, because our next presentation, which is going to be by video, is from our colleagues in Calgary. And it is about how they implemented a program called See the Patient. See the Person. Our presenters are going to be Dr. Marge McGillivray, who's the geriatric ED lead at South Campus in Calgary. Paige Guinn, who's the geriatric ED nurse practitioner at the same site, and Jennifer Young and Teresa Gutierrez, the senior health educators in Calgary. So we'll watch the video. If you have questions, they are on the panel, so they're able to answer questions also.
An Alberta Dementia Strategy and Action Plan, which outlines a number of goals, including the provision of a trained and supported workforce. Seniors health educators are supported by their leadership to deliver educational sessions to other departments, including the ED. The South Health Campus ED is a 30-bed ED that sees approximately 67,000 patients per year. The proportion of patients over 65 is 16%. Due to limited inpatient capacity, we hold many admitted inpatients in our ED.
One of our educators in the ED was able to attend the full See the Person session and thought it would help improve elder-friendly care in the department. Developing a 2-hour session tailored to immediate ED practitioners' needs was more feasible and sustainable than the full-day workshop. Leadership support and buy-in was crucial from all stakeholders as we care for older adults. Without involving the entire team in training, knowledge translation to practice is difficult to achieve. Seniors health educators provided 2 sessions per day, 2 to 3 days a week over the span of 6 weeks. All full-time staff were sent for the session on days they were already scheduled with backfill provided. Casual or part-time staff were asked to attend on their days off. Funding for the session was approved by management with no overtime pay used, and it did not apply to staff's allotted education days. To support the collaborative care in the the ED physicians and ED residents were also provided a session.
We worked with ED stakeholders to draw out 3 common scenarios and experiences in the area. This included calling out, a fight response related to intimate care, and supporting encounters involving retrogenesis. Within these scenarios, we provided content for staff to better understand why these behaviors may occur, and strategies that could be immediately brought into practice were then explored. The objective was to improve patient care, increase staff comfort and confidence when working with these clients, as well as improving job satisfaction among staff.
The 2-hour workshop was extremely well received, and a transformational improvement in elder-friendly care was noted in the department. As a result, management added this session to the new hire orientation. In addition, for those who attended the 2-hour session and wish to further improve their skills, we are offering a full See the Person session 2 times a year.
In order to take the first steps to implement this educational initiative, it was important for our staff and leadership to acknowledge that a problem existed with caring for our older ED patients that were living with dementia and delirium, and realize the benefits provided by delivering this workshop. Manager support was crucial in committing staffing, augmentation, and funding, which allowed for mandatory attendance for all of our ED RNs and allied health. The seniors health educators and executive leadership support played a vital role in delivering this educational initiative to our ED.
Good. Thanks a lot, Calgary team. Sounds like an awesome program. I'm just going to ask a question to one of you. If you could just describe briefly, like thinking about the one on calling out, which is a behavior that drives emergency clinicians crazy. It's already a noisy place, and having one more person calling out. What would a person who'd gone through your program, how would their behaviors and attitudes be different? Paige or Marge? There, you're off.
I can start a little bit, but then Paige can maybe fill in. She might have some other insights. So from a physician standpoint, and my attending multiple versions of this workshop, I think, again, we were educated by the Seniors Health not to understand, again, like the pathophysiology of dementia, as well as some of the experiential sensory deprivation or changes that happen in normal aging. And we also included our ABCDs of agitation tool within this educational session, which in this scenario, like the calling out scenario, I think would be applicable. Paige, I don't know if you want to jump in there, but again, just, trying to determine whether or not there's some unmet care needs. So we talk about A, is the patient needing analgesia, B, bladder, C, constipation, D, diet, dehydration. So I think that's one of the main things that was sort of incorporated into the See the Person workshop. Paige, I don't know if you have any other points.
No,
there.
that's the main thing, is our staff learn to kind of live with the calling out, but also work through the why are they calling out, and not just think it is their dementia. Is there a reason behind it? And work through that ABCD tool. That has been probably the most beneficial, is trying to find if there's a source for them calling out and work through their care needs. Is it whether it's going to the bathroom, which is usually the main one, is they need to get to the bathroom and they don't know where that is, and they aren't able to communicate that with our staff effectively.
Good. I think it's an excellent example, as was Pam's, of changing attitudes to and also adding skills, which is skills, knowledge, and attitude is what education is all about. Thanks a lot. It's a very inspirational program, and amazing that you were able to roll it out. I think everybody would be interested in, if you want to put into the chat some ideas about how you could convince your leadership to support that as well. So we're going to move on to Maura at this point. So dementia leads us naturally into delirium. You've been doing a lot of work, Maura, on many different areas of geriatric ED care, but you've been quite involved with a particular program around delirium education. Can you tell us about that?
Absolutely. So I'm going to talk about the ED-DEL change package and toolkit. And honestly, it's much more than just education. So it is developed by Dr. Sharon Inouye, who is an expert in in delirium detection and delirium prevention, really a world expert, and was supported by the West Health, leveraging many experts from the GEDC, and had a multidisciplinary group informing it. So physicians, nurses from the emergency department, geriatricians, and pharmacists. And importantly, this whole toolkit was then trialed in a number of emergency departments that are now accredited geriatric EDs before publishing it. So it's available online for you. And it is a step-by-step guide to help you if you're interested in any sort of program related to delirium in your emergency department. Maybe it's improving detection, maybe it's improving management, or assessing for how you could prevent delirium in the ED. So how does that relate to education? Because this is not about delirium, it's about education. Really, education is a cornerstone for change practice. You have to include education initiatives at the outset of any practice change that you put into place. And so within ED-DEL itself, there are 30 pages of the appendix devoted to educational resources that have been trialed and that you can use and adapt for your site. They're multifaceted, again, developed by multidisciplinary groups, some targeting more nurses, some targeting more physicians, and ultimately, hopefully making it easier for you as you're going on your delirium journey. One of the things that Dawn asked me to talk about are what are some of the considerations I have when trying to think about educating the emergency department workforce around delirium. And I have a few things that the ED-DEL really does address well, which is what is the content you need to deliver? So if you want to detect delirium better in your emergency department, you probably need to tell them what delirium is, or if you're implementing a tool or an order set, the nuts and bolts of that education are going to be important. But you're going to need to go a little bit deeper and think about other things that the workforce needs to know beyond just that tool that you're implementing. Thinking about why it matters, who is going to deliver that education, and how that education is delivered. And when you're thinking about how to deliver the education, trying to think through a multifaceted approach, things that are more memorable, and trying to make it easy for you or for your team. And hopefully ED-DEL will help you with that. So I'm going to go through a few of those topics and give sort of a delirium framework to it. In terms of the content, again, maybe you're rolling out a new tool and you need to educate people about that tool, but why are you looking for delirium in the first place has to be a part of your education. And one of the reasons it has to be a part of your education is emergency physicians and nurses think they're great at detecting delirium. In fact, we did this survey and 77% of emergency nurses and 93% of emergency physicians said they're intermediate or advanced at detecting delirium, but we miss it 2/3 of the time in the ED. Right? So you have to address those misperceptions, the knowledge gaps that might be there, and correct what we don't know, or what we think we know, but we don't actually know. So that may be understanding what inattention is, or probably understanding hypoactive delirium, because most of us can recognize or react to hyperactive delirium. So the content is important, and I think this has already been addressed by other people, but the why this matters is really important. For most of us clinicians, the patient perspective is important. So understanding from a patient perspective why diagnosing delirium or preventing delirium is important has to be a part of your education, but there might be other things from a clinician perspective you want to highlight. Or if you're trying to get buy-in from your C-suite, you may be wanting to pitch slightly different why this matters. If you just say, because I said so, you might get initial action, but you'll get it with reluctance, resentment. I'm a parent, I know that very well, and it won't really be effective for long-term change. The other thing that we talked about was who is delivering the education. So a great example from my institution was a few years ago, the nurses in my emergency department said, we really don't get much teaching on geriatric care, and we care for a lot of geriatric patients. Can you help us with this? And I said, yes. Let me find out who can give you that education. I didn't step in to give that education because I don't really have the knowledge skills to teach a nurse about excellence in geriatric care in the emergency department from a nursing perspective. but I knew who to find and I could help that. I could support that. I could buy them breakfast for their grand rounds. I could find excellent educators and support them coming to teach the nurses. And I attended that and I learned a lot. And the things that they taught were different than what I would have taught if I was teaching a physician group and had a lot of those experiential elements that were already discussed. So thinking about who is going to deliver the education sometimes appears much more effective than an administrator in delivering the education. And then my last little tip is around making it a multifaceted, memorable, and easy education experience. There are times you have to do a PowerPoint slide. There are times you have to do a lecture. And there are times that is a very effective approach. But try and think about multiple approaches to provide the education or to reinforce the education. So 2 months ago, one of the residents at my institution selected a case for M&M that was a patient who developed delirium while boarding in the ED. I've already talked about delirium prevention to my residents, but this was much more effective than my lecture because it was patient-based, it was delivered by their residents, and it was a patient that came in without delirium and while in the ED developed delirium. I think it really brought that patient perspective and why that mattered and something that they could do better. On the memorable end, if any of you are delirium nerds, World Delirium Awareness Day is in March of every year, and it is an international day of education around delirium. It is so awesome. 3 years ago, they had this quiz you could take to find out what type of delirium hero you were. This year in March, someone had this phenomenal spot the difference where they had 2 pictures, and you had to try and figure out what was different between the 2 pictures, and they were all about delirium prevention. Were the blinds up or down? Did the individual have their glasses? And then most places actually that are participating in World Delirium Day do something locally too. So across my institution, we did fortune cookies. And I did it not just at my emergency department, but I made it easy for all of my system EDs. We bought it for our emergency department in Martha's Vineyard, on our North Shore. And so it was across our institution in our emergency departments, fast facts via fortune cookies. And then just sort of bringing it back to EDDEL. So again, EDDEL is a whole change package toolkit. So it doesn't just have this education material. It has information on how to prevent delirium, sample order sets, but within it is 30 pages of education material, delirium badge backers that people have used at Maine Medical, fast facts from St. Mary Mercy, and honestly slide decks that you can adapt. So content for slide presentations if that's what you need to do.
Thanks a lot, Maura. That's a lot of stuff, and there's more where that came from. I think several of us on the screen here, Pam, myself, Eula, possibly a few others, were involved, and Maura certainly were involved with Dr. Inoue in developing the program. And importantly, as you pointed out, it's like been road tested. It's been rolled out in several high performance emergency departments around the United States. And there's a lot of learning, and all of that's completely available to all of our listeners and everybody else on the GEDC website. So delirium brings us to delirium prevention, which is brings us to mobility. So we've got another example of a real life example of education. Now we're going to Wisconsin to hear from Suzie Ryer. Suzie is a welcome return visitor. She was here for our Falls Assessment webinar a while ago. She's a geriatric specialist with a doctorate in physiotherapy, actually quite recently. Congratulations, Dr. Ryer. And she's a project manager, project coordinator with senior service at Advocate Aurora in Wisconsin and Illinois. She's going to tell us about their education program as they rolled out a Falls program across a whole system of hospitals across Advocate Aurora. So we'll turn it over to Suzie by video.
Hi, my name is Suzie Ryer, and I'm a geriatric physical therapist and project coordinator within the Advocate Aurora Health System. I'm here today to talk about the education we created to support the implementation of the Falls protocol for patients presenting to the geriatric emergency department after a fall who are likely to go back home. The protocol was designed to standardize patient identification, mobility screening using the timed up and go test, and care transitions focused on connecting patients with post-discharge resources for fall prevention. To meet the needs of our many geriatric emergency departments within the system, The protocol was designed to include standardized processes and outcome measures while still allowing for some customization based on the community served, available resources, alignment with other department initiatives, and the background of the staff. In order to train the workforce, the comprehensive education was developed to support the interdisciplinary team in implementing the Falls workflow. The education was developed with input from bedside nurses, physicians, case managers, social workers, and physical therapists. Key components of the education include background on the impact of falls on older adults, fall risk factors, an overview of our falls protocol and the evidence-based interventions we selected to include, videos on how to perform various screenings and assessments, including the timed up and go, and instructions on how to document and place discharge referrals. The education also highlights the unique role of each interdisciplinary team member in caring for patients who have fallen, with a particular emphasis on the role of the physical therapist in assessing mobility, balance, and providing discharge recommendations, as this discipline is newly integrated into the emergency departments in our health system. The education was designed to be delivered in its entirety, but it's also able to be split and customized based on the site's need and the specific audience who it's going to be delivered to. Some of our sites have taken the education and divided it into discipline-specific modules, adding details around mobility techniques and communication strategies for nurses, as well as specific instructions for how to place orders for our physicians. A variety of methods have been used to validate staff understanding of the education. This has included quizzes on some of the didactic content, as well as skills checks on performing the timed up and go test. Case studies based on actual patients seen in the emergency departments have been used as part of our initial educations, as well as refresher sessions to engage critical thinking, identify success in the delivery of our protocol, and provide opportunities for improved care. We continue to provide ongoing education as part of our annual geriatric emergency department boosters, our monthly site Geri ED team meetings, as well as regular ED staff meetings. As we continue to implement this protocol at new sites, as well as try to provide additional education to a large number of new team members at our existing sites, we're hoping to move our education into a web-based training format. Thank you so much for taking time to learn about our program and our education.
Thanks a lot, Suzie. Very inspirational program also, and a big one to roll out. It's trying to find something that works across 15 or 20 hospitals is not easy. If for those education nerds in the audience, when we think about skills, knowledge, and attitude, I think Suzie just gave examples of how their education broke down into all three. The ones that I counted would be skills, which is teaching people how to do a tug, knowledge, identifying what the risk factors for a fall are, but then also changing attitudes of why falls are important to older people and why it's important for us to change our attitude about them. Suzie, I one question for you. Can you give an example of how the rollout would have been different at a larger hospital, what you did at a large hospital in an urban center versus what you did at a smaller hospital in one of your rural sites?
Yeah, thanks, Don. Good question. I think in our larger sites, just with a larger number of workforce to train, we had to rely a lot more on, kind of large blast of education, whether it was distribution of a PowerPoint for that initial, didactic learning, and some of that quiz format where we could just kind of sample a large group of the audience initially. But then the other thing that we really had to leverage at our large sites was really engaging champions as well as interdisciplinary team members who could really help to build the education workforce. So at those sites, it was, the PTs who consult in the ED who were coming down and helping with tug training, along with the nurse educators, along with, members of other teams. And so it really is about, expanding that reach versus at our smaller sites, it was much more personalized where we could take, that training session, really look and kind of model that to be very specific to the examples that were occurring in that site, down to you call this person on this day because you could adapt the protocol down to such a small scale. So, it was really just knowing the teams and really having a good understanding up front before we rolled the education out.
Thanks, Suzie. Yeah, it's a good example of how like the making it real, the real life, practical in my site, in my life is what makes education valuable. You can't, whether no matter how good the tool that you're trying to roll out, EDDEL or your FALS program or whatever, you're going to have to do something a lot at your site to interrogate your users. What is it that they want? What is it that they need to make it valuable for them? Thanks a lot. Now, I just point out that it's hard to keep track of everything. There's an awful lot of good stuff in the chat here. The chat, if you can't keep up with it now, the chat is fully available on our website after the fact, so you can pick up on some of these resources there later. We're going to go over to Tony in New York City. You're the person most identified with education around elder abuse, and you've been involved in a very important project over the last couple of years to develop education. Can you tell us about that initiative, please?
Sure. Thanks, Don, and thanks everybody. I know we've heard a lot of really good information, and so I'll try to sort of briefly boil it down from an elder mistreatment perspective. This is certainly an important issue, and one on which many folks that are on this webinar have contributed to developing what is the Elder Mistreatment Emergency Department, or EMED toolkit. Connor's going to put it in the chat, but that toolkit is also available on the GED Collaborative website. And similar to EDDEL, it, we hope, provides a comprehensive set of tools that are needed to really address this in your emergency department. Most importantly, there are learning modules, given we're talking about education. And so there are key learning modules. We know the importance of asynchronous education, but also, and I'll talk very briefly about some of the key components, there's what's called a community connections roadmap, because ultimately this is true for a lot of different things we deal with in the emergency department, but particularly for elder abuse. Caring for our older adult patients doesn't end with us. It's about connecting to the community and giving people tools to do that in different communities is critical. And so briefly, the core of this toolkit is what's called the EM SART. It's actually the EM screening and response tool, which has two parts: a brief observational and 3-question screen, followed by an in-depth screening and response protocol. So if folks don't yet have a protocol, or a protocol that they're comfortable with, this is a protocol that you can use. In addition, as I mentioned, there are interactive e-learning modules. And one of the things that we haven't talked too much about, but Suzie Ryer brought up, is that there are modules both for providers and for clinical champions. We know that driving a lot of this change and driving a lot of this education is educating a local expert and empowering a local person to feel like they're able to train others. And so focusing on clinical champions, we think, is a key piece of this, and likely is a key piece of a lot of successful education. Also, as I mentioned, there's a community connections roadmap, which describes sort of step-by-step how your champion and others can build relationships in community partnerships that exist already, strengthening them, or reaching out to folks that can be helpful, folks that are probably excited to work more closely with your emergency department and to care for your geriatric patients. And I know that Don Melady has often said to me, and is quite right, that a lot of elder abuse and neglect is unmet social needs, and connecting to community resources is a critical way, and teaching your staff about community resources that are available is a critical way to improve care. This toolkit, it was created by the National Collaboratory to Address Elder Mistreatment, and Connor, I think, put a contact information for that group in the email. You can certainly contact me. Connor, I hope, put my email address in that as well. We're really grateful to the John A. Hartford Foundation, the Gordon and Betty Moore Foundation, the Health Foundation of Western and Central New York, all of whom gave really important contribution to this. And just as ED-DEL, this work was not done by emergency providers. It was done also by geriatricians and also by social work experts. And I think that that kind of multidisciplinary piece is critical. One other key thing for us is this is a work in progress. We want feedback. We're looking for feedback. We're looking to improve. As ED-DEL, this was developed and feasibility tested in 5 different sites, which have very different profiles, but they might not be like your site. And so knowing what your site needs may be helpful to all of us. In fact, there's a survey that's part of the training, and you can think about having your staff do the survey before to see where your gaps are, to see what your needs are. People like to get asked their own opinion as part of education, and that can sometimes be an important tool. Also, the last piece for us about elder mistreatment is elderabuseenergency.org. We designed a website, and one of the reasons we think that piece is important is that we're ER docs and ER nurses and ER providers, and sometimes you don't need information about something until 2 in the morning on a Sunday morning when you'd like it right then. And so in some ways, thinking about just-in-time education is an important skill. You know, in the old days, I think we used to look at textbooks at 2 in the morning in order to figure out what to do. And now we need on-demand education to help. And so I think that's a key component. Also, you don't have to wait till March. World Elder Abuse Day is June 15th. It's coming up soon. And so if you want a theme-based approach to that, I can tell you that in our emergency department, we're focusing on unmet social needs and partnering with our social workers. And so there are opportunities for all the topics you're hearing about today to focus on things on days when they might be hearing about it in other parts of their life as well. 2 other key quick things, not necessarily related to elder mistreatment, but that I wanted to add that Dot asked me to discuss. The first is interdisciplinary education. Maura brought up, and I thought it was really important, the who giving the education is important. And I think that for something like elder mistreatment and many other things, sometimes the experts aren't the physicians or the nurses. And any time that you can have non-physicians and nurses delivering education, I think that's a win. Having pharmacists, having social workers lead training, it empowers them. It reminds everyone that we are a multi-interdisciplinary group that cares for older adults shoulder to shoulder. In addition, as Don pointed out, I think it's really important that education doesn't just be for us that provide the direct clinical care. Our social workers can benefit from education. Our patient care techs can benefit from education. Our physical therapists, our escorters, our clerks, our EMS providers, all of these folks are critical, and empowering them and ensuring that they get education can be really effective for geriatric emergency medicine. And I think I learned this last piece from either Tess Hogan, who may be on, or many others of you, but stealth geriatrics is critical. And we heard a little bit about stealth geriatrics from some other folks, but think about sneaking, and it's not sneaky, it's good. Think about sneaking geriatric emergency medicine principles and approaches into already existing training. That Thursday AM SIM case could be a delirious older adult who fell. That in-service and huddle message could be about improving safety and efficiency of discharge processes, focusing on assessing for dementia, ensuring understanding in high-risk older adults. Updating on pneumonia or sepsis for Wednesday conference may include or even focus on specific issues around considerations for assessment and management of the older adult. Regular interpersonal violence training may focus on identification and next steps for elder mistreatment. So these are the ways that you can sneak it in to the existing curriculum. And so with that, I know I've probably gone on too long. Thanks, Don, and thanks, everybody.
Thank you very much, Tony. Can't be too long. We can never have too much of you. Thanks very much. And now we are going to move on to our last quick hit video. And it's going to be Dr. Colleen McQuown, who is a staff emergency physician from Lewis Stokes Cleveland VA Medical Center, to talk about their Geri Vet program, which showed that's their intermediate care technician program, I think. Please try to concentrate on what Colleen is saying in the midst of that spectacular back garden of hers. So over to you, Colleen. You may need to turn up your...
I'm Dr. Colleen McQuown from the Lewis Stokes Cleveland VA Medical Center, and I'm here today to talk to you about how we trained a novel workforce within the VA to perform geriatric screens and care coordination. This workforce, called intermediate care technicians, is made up of former military medics, Army medics, Navy corpsmen, Air Force corpsmen, who come to the emergency department and the VA with a wealth of knowledge from their time in service. However, they primarily took care of patients 18 to 30 years old and have very little geriatric experience, but are really able to connect to veterans. So because they had no geriatric experience at all, we started out with doing some baseline asynchronous training, doing some modules online of introduction to geriatrics. What is geriatrics? What is the difference between treating older patients and younger patients? How do you communicate with older patients? Then we had them do narrated PowerPoints asynchronously that went over how to do all of the geriatric screens, how to do care coordination, how to do chart review, and also how to connect veterans to specific VA services and community services. From there, we added in an dementia experience to be able to understand what it's like to have dementia, and so they learn empathy towards patients and towards their caregivers. We also do pair them up and do practice screening. So they do all of the geriatric screens on each other, practice ambulating, learn how to use mobility devices, learn how to use a gait belt, learn about all of the different products that we give out from the VA that we can order for our patients, like walkers and 31-day pill boxes. Then they do a series of cases in the sim lab where they have a patient that's delirious and won't listen to them until they remind them to get a hearing amplifier out. We have a case where a patient has dementia and is becoming agitated and trying to leave, and that patient needs to have either given food or drink or some kind of fidget toy to be able to distract them while they're talking to the caregiver. We also have the caregiver involved, and they have to ask the caregiver for medication list. And then we go out and have them actually practice them on patients. They shadow us, they watch us watch the experienced screeners who do all of the screens. After they watch so many screens, then they get to do them themselves, and then we sign off on specific competencies forms for each screen that they do, care coordination, follow-up phone calls, and doing the presentations to the attendings to come up with a care plan in the emergency department for these patients. Thank you.
Thanks a lot, Colleen. And Colleen's on the line here. And if we have time for a question, please chat it in. As I said in the text box, I mean, I think it's a really amazing program that demonstrates the value of education, where you can take somebody who doesn't really know much about older people and turn them into a practicing expert. In the interest of time, I'm just going to keep the last part of this brief. I did want, we've talked mostly about sort of live or in the department or true didactic education. I did just want to bring up as my contribution the value of asynchronous or online e-learning, which is one of the components of a successful educational program. Sort of addresses the just-in-time or on-your-own-time education. So many of you are familiar with geriem.com. It's a resource that was developed here at Mount Sinai by our team that's been in use for 9 years. The important things that I want people to know about it addresses 6 different modules within, or 6 different topics within geriatric care. That builds on the work of Dr. Tess Hogan at Chicago, who really allowed us to delineate what it is that emergency doctors, nurses, and other clinicians need to know in the emergency department about older people. And this speaks to the essential factor that emerge doctors and nurses don't want to become geriatricians. They want to be emergency doctors, and they want to provide good care to older people. So there's a fairly narrow scope or range of stuff that they need to know, but there are things they need to know. How to identify elder abuse, medication management, why trauma, the most common presentation of trauma is falls, intoxications, how to work with a team, how to identify atypical presentations. So these are the core competencies of geriatric emergency care. And I think Connor is going to text in the reference to Tess's work, which is essential for anybody designing geriatric emergency department education. All of these modules are also accredited so that the person doing the work can get the credit for the work. But they're also multimodal, and that's a term that came up earlier. So it can't just be listening to watching a PowerPoint on a screen or watching a talking head. There are multiple different ways of presenting the learning, using simulation, using quizzes, using games, getting feedback from an expert, or getting feedback from your peers. All of these different strategies help people learn. And then it also needs to be kept up to date, which is going to be my final point. After 9 years, we have been able to fully upgrade geriem.com, thanks to the Geriatric ED Collaborative. And working with my Geri-EM fellow this year, Dr. Marie-Pierre Lanoux, who's on the call, we have completely upgraded and updated the content and added 2 new important modules, which are on frailty and what the emergency doctor and nurse need to know about frailty, and major trauma resuscitation for older adults. And all of those things are going to be available on the GEDC website probably by the end of the month. They will remain free, open access, but fully accredited. This time they'll be accredited through the Mayo Clinic system. So that's something that you can keep an eye on as we're coming towards the end of this academic year. Can we go back into the slides, please? So I just wanted to round up with a few other examples of educational resources that we have on the website, which are quite a lot. Both in all different forms, including the ones that have been mentioned here today. Next slide. Thanks. There's also the Geri-ED clinical curriculum, which covers a number of topics as well, which you can access, some of which are available for credit also. And next slide. Yes, if you, we did mention earlier that education is necessary but not sufficient. You need to be working within a system of care that allows you to provide good care. If you're interested in making some of the system and management changes, I would direct you to a recently published book by 2 GEDC faculty, myself and John Schumacher. If you want to save yourself $6, there's a discount code available for GEDC users. Next slide. Eula, do you have any closing comments about important themes that came up?
Yeah, so tremendous webinar. I think some really great examples of some outstanding implementation toolkits that have been created. There's no reason that you need to start from scratch. I think check out these resources that many of these experts have really pulled together and have successfully implemented. I think the main theme that I would say here is empathy. Really, having your clinicians and the staff that you're trying to really engage and do this work, experience in whatever way they can what an older adult might be going through in the emergency department. I do want to just give some quick stats again. Always great showing of a diverse group of members in the audience from all around the world and all around the country, from Ireland all the way to the west coast of the United States, from the east coast to the west coast of Canada. We've got all different kinds of health systems, Indian Health Services, the VA, private groups, and then we have all different representations, from nurses to program managers to geriatricians to emergency physicians to social workers. So just again, a diverse group, and it takes a village to do this work, and everybody that participates in this, I think that opportunity for us to really experience a little bit how we can do a better job in improving care for our older adults. We're all here to show and teach each other, and you just heard from a tremendous group of experts who are doing this on their front lines. Thank you.
Thanks a lot, Eula. As usual, we talk too much and don't have time for an abundance of questions. Lots of things answered in the chat box. Our next webinar will be August 8th in the dog days of summer. I hope that you'll come back from the beach to participate. It's on a slightly different topic, value-based care. So some of the sort of more financial and management issues relating to how you can shift priorities financial priorities of your hospital to improve the quality of care in your geriatric emergency department. So August 8th at 3 p.m. And final slide, please join us. Next slide, true final slide. And that's to say, once again, thanks to Johnny Hartford and the West Health Institute, and thanks to all of our participants, the video stars, as well as the live stars, and thanks for the behind-the-scenes crowd at the GEDC, Laura and Connor and Lorraine. See you all in a few months. Thanks for being here.